All right. Good afternoon, everybody. I'm excited to introduce the Pali Psych Collaborative. Today, we're joined by Dr. Chammas from UCSF, Dr. Brenner from Stanford, and Dr. Shalev from Cornell. They are three of the four founding members of the Pali Psych Collaborative, which is a multi-institutional group of palliative care providers who have additional background training in psychiatry and/or psychodynamic psychology. Founded in 2021, the Pali Psych Collaborative's mission is to contribute to the greater field of palliative care by integrating high-yield knowledge and skills from psychiatry and psychotherapy through education, training, research, and scholarship. The Pali Psych Collaborative has published multiple articles, delivered numerous grand round presentations at academic medical centers throughout the country, and led national and international training workshops. And we're lucky that they're joining us today. Please welcome the Pali Psych Collaborative.
Awesome. Thank you for the kind introduction. Keri, Dan, and I are so excited to be here today and to get to talk to you all about a topic that we are super passionate about, which is teaching psychotherapeutic concepts to elevate palliative care practice, shifting the educational paradigm. And in terms of disclosures, or perhaps more of a gratitude, the one thing to mention is that the Cambia UCSF Endowed Fund for Palliative Care Innovation has generously provided funding in the 24-25 academic year to study the use of process rounds in palliative education, which I'm so remarkably grateful for, and you'll hear more about that work today.
So I'd love to just acquaint us with our objectives today during this time together. Our first hope is that we'll understand the scholarly and educational advancements of integrating these psychotherapeutic concepts with serious illness care. And we love that we're presenting this to a geriatric and palliative care audience today because it's awesome to think about the applicability to geriatric care. Second, we want to be able to define this concept of psychological formulation and to explain its relevance on how it can enhance care for patients with serious illness. And finally, our final objective is to develop and practice the skill of utilizing formulation and how that can guide and inform our therapeutic communication choices when caring for patients with serious illness.
So I will share with you all that my current practice is actually in general palliative medicine, but every single day it is so deeply informed by my psychiatry and psychotherapy background. And when I was a trainee in psychiatry, we spent a lot of time thinking through ways to conceptualize the psychology of a patient, the dynamic in a room. And then I shifted over and came to palliative care training. And what was consistent was that the importance of communication was still deeply emphasized. But what felt very different to me was that the focus shifted almost exclusively on tools, communication tools, communication algorithms, communication scripts. And a huge part of integrating my training into the clinician that I am today has been sort of creating a paradigm for mapping the conceptualization of the psychological elements of care with all of these rich communication tools and skills that I was taught in palliative care training. The two so deeply inform and elevate each other. And when we talk about these psychological elements of care, there are so many psychotherapy concepts that are at play all the time in medicine settings and palliative care encounters, everything from our psychological formulations to countertransference, attunement, holding, any number of things. And this has really been the space where Keri, Dan, and I have been doing a lot of our joint academic work together.
Over the past couple of years, a significant component of the more empiric work that I and my colleagues have been doing has been focused on documenting training needs at the interface of palliative care and behavioral health more broadly. And in the context of that work, we found that despite the really heavy emphasis on communication and palliative care training, fewer than 20% of palliative care fellowships actually include any psychotherapy-based skills training to guide that communication. We also found that practicing palliative care clinicians across settings and all over the country are generally dissatisfied with their access to opportunities for professional development with these kinds of skills. But fortunately, we've got a paper coming out that's a light of hope that shows that even light resource interventions like webinars or lectures actually predict satisfaction with that training pretty significantly.
Before we dive into our data, we wanted to give you a snapshot of our background work. So there have been such a multitude of contributions and initiatives from a medley of institutions and scholars that predate us. And truly our PolyPsych Collaborative stands on the foundation of all of that scholarship. An important inflection point within our group was in 2019 when a Harvard Radcliffe exploratory seminar commenced. And I co-directed that with Vicki Jackson and Leah Rosenberg from MGH, where we gathered over 20 experts from a variety of disciplines from around the country to explore the psychological elements of palliative care. That then led to a 2021 Journal of Palliative Medicine series that was generated. That was an 8-article series that various groups of us did. And those publications were really focused on the psychodynamic topics of caring for patients with serious illness. Topics like attunement, attachment, frame, boundaries, holding environment, formulation, and how these can relate to everyday serious illness care. So how do you take the concept of the frame from the world of psychotherapy and actually apply it to our everyday practice with clinicians when we're not psychotherapists, when we're geriatricians or palliative care doctors? That then led to the PolyPsych Collaborative coming together in 2021. And the three of us are founding members, along with Leah Rosenberg from Mass General. And our mission in the collaborative, as spoken in our introduction, is to contribute to that greater field of palliative care by working very synergistically to deepen education, training, and scholarship at the interface of palliative care, psychiatry, and psychotherapy. So we're going to post in the chat our website where you can see some of the work, the lectures that we've given, the productivity that we've had to date from that collaborative, which has been just such an enriching initiative for all of us. Then in 2023, our PolyPsych Collaborative did a grand round series, and it was the 4 of us as founding members that were invited to 15 different major academic centers throughout the country. And we did these 15 different lectures. They were all virtual, 1 hour. Most of them were grand rounds in terms of their format. And they focused on the topics of formulation and countertransference and their applicability to the field of palliative care.
Around that time, we really began to get more serious about collecting data to guide the work that we were doing and the growth of this paradigm. We collected very brief surveys from our grand rounds participants across institutions and found that our participants were really highly satisfied with the content. But the primary critique that we were getting was the need for more time, more content, and more opportunities for interaction, which the grand rounds didn't lend themselves to. And that gave us a lot of direction for the next steps that we took.
So moving forward on that next step in our timeline, it brings us to this year in 2024, which has been quite generative, where our group has begun to produce a lot of educational content in various modalities. And the predominant educational format that we've used is this workshop. We first commenced the workshop at American Academy of Hospice and Palliative Medicine, AHPM. That's our national mainstay conference for palliative care clinicians. We then have another workshop for the Social Work Hospice and Palliative Care Network group in August, as well as an international workshop at the McGill Congress that will be a pre-conference in Montreal in October. So here's a picture of our group, all of us together. We're a full interdisciplinary team that also includes social work and spiritual care expertise. So this is just a glimpse of our workshop that debuted as that pre-conference at AHPM this past March of this year. And we designed this as a 4-hour course in person with 72 participants that were there. And the course was intentionally designed to be very engaging with immersive learning. So the main topics that we covered over those 4 hours were the topics of formulation, countertransference, and then therapeutic techniques for how do you take those concepts of formulation and countertransference and actually integrate them into communication skills and therapeutic presence to patients. This is a bit of the evolution of that AHPM workshop. So we gave it for our AHPM National Conference in March. That was the half-day in-person immersive workshop that focused in on the psychological elements of palliative care. And then after we delivered that workshop, we gave an opportunity for folks to participate in process rounds. The process rounds were 4 sessions that were optional that we offered virtually, where attendees would come to those 4 sessions, and Danny and I helped moderate it, where they would bring real cases they were seeing in real time, present those cases, and Danny and I would help guide the group to think through those cases through this lens that they received at the workshop, thinking it through in terms of countertransference formulation and therapeutic techniques. So that really consolidated and hopefully deepened the learning and built people's confidence skills in terms of implementation in their everyday practice. In May, we did an 8-week survey follow-up, both for people who simply attended the workshop back in March, those 72 attendees, and then also people who did the subsequent process rounds voluntarily. And we're still measuring that data because we're working on iterating and refining that workshop accordingly.
So we haven't finished data analysis yet, but we wanted to share just a little bit of what we found. So for our workshop, we designed a survey that we hoped would at least nominally integrate the full range of Kirkpatrick educational outcomes. Our 71 participants were predominantly physicians and nurses practicing in a range of hospice and palliative care settings. Even prior to the session, the vast majority of our participants were self-selecting in that they felt that integrating psychological concepts into their practice could improve their clinical palliative care practice, which is not a surprise since they signed up for our pre-con. The majority of our participants were, I think maybe next, there we go, yes. The large majority of our participants were extremely satisfied. Almost all were either satisfied or dissatisfied. As a note, we've got a 9% group who are extremely dissatisfied, but who all wrote uniformly glowing qualitative feedback for us, suggesting they may have inverted the Likert scale. And here are a few examples of some of the items that we asked and how they map onto the Kirkpatrick evaluation model. There were some differences in the surveys at every stage, but we maintained many of the core items to really allow us to map change. The majority of the items across each Kirkpatrick level, we were able to detect a significant increase between the pre-survey and the 8-week post-survey, with no significant loss between the immediate post-survey and the 8-week post-survey, which was very encouraging for us. We also maintain that agreement on the importance of psychological concepts in our work. Although we had some attrition in terms of getting folks to respond to our 8-week follow-up, the 30 or so people that did respond almost uniformly agreed that the workshop had impacted their interactions with referring and consulting clinicians, their education skills in palliative care, and their palliative care clinical practice, which we found really validating and reinforcing.
So we wanted to give another panoramic view of the evolution of this workshop. Back in March, we did that half day in person on the psychological elements of palliative care for AHPM. Then in April, Danny and I actually did a pilot for the UCSF and Stanford palliative care fellows, which was really fun. They all came to Stanford and we did a day together on that same workshop material, the psychological elements of palliative care. In August, we will be presenting for the Social Work, Hospice, and Palliative Care Network, and that will be another half day. However, that modality will be a virtual workshop, and we will modify it knowing that social workers already have a pretty robust foundation in these concepts. So it'll be more on the education and integration of it into the IDT format and how they can teach it more readily to palliative care clinicians or those caring for serious illness. And then in October, that's when we'll be presenting for the pre-conference at McGill in Montreal. And we'll be expanding out the content at that time where it will be a full day, not simply on the psychological elements of palliative care, but also the psychiatric elements, such as how do you treat depression, anxiety, demoralization, delirium, assessment, and management.
So now we go to the part of, oh, sorry, you go, Keri.
For every time that we give that workshop, we also offer this voluntary optional opportunity to do process rounds. And when we say that, we mean those 4 virtual sessions where Danny and I are available, where people can bring their real-time cases and process it through the lens that they received in the workshop. And we're studying each of these workshops as well as the subsequent process rounds right now, and that data is still being collected.
So now we get to the part of the talk that's always the most fun for me. We obviously don't have time to go into all of these psychological elements, nor do we have a workshop format, but we are excited to spend a little bit of time together talking with you guys about this concept of formulation, zooming in on this one element and giving you some exposure to the concept. So as we sort of prepare to think about the concept of formulation, the question that I'm going to put readily into your mind is, what tools do you need to fix it? If I were to go to a mechanic right now and say, my car is broken, what tool do you need to fix it? there is no way they could answer that question, right? They would need to run a diagnostic first that would probably charge me a pretty penny for it. And similarly, if I were to call in one of the internists in the audience right now and say, I've got a patient with chest pain, what tool do you need to fix it? You'd probably roll your eyes at me because you would first need to make some kind of assessment about what was causing the chest pain before you could quote unquote fix it. One of our cornerstones in medical practice is that assessment comes before plan. And our hope for today, when we talk about formulation, is that you begin to feel the same way about communication, particularly when we want to use our communication therapeutically or as a therapeutic intervention. We talk a ton about tools in palliative care. We have, acronyms and nurse and this and that. But in the psychotherapy world, a therapist answer to the question, which communication tool do I need to use right now, is almost always, it depends on my formulation. So let's get super concrete. We're going to illustrate this concept from the therapy world before we switch it over to applying it to the geriatrics and palliative care world. We are the audience, you all in the audience, or we're the therapist, you all in the audience and myself, and we're sitting in our therapy office, and our patient, Keri Brenner, comes in and says to us,
I was 20 minutes late to pick up my daughter from school. I am so disappointed in myself. I'm a total failure as a mother.
so what do we say to her? What communication tool do we use to be therapeutic to her in this moment? And I know what you all are thinking right now. You're thinking, this is a trick question. And you are absolutely right, because the answer is, of course, it depends on our formulation. Let's pretend that the patient in our office saying this phrase is Maya. And we have learned through getting to know Maya over time that her past experiences have led to a core pathological belief that she is responsible for anything that goes wrong. Right? It is not okay for her to make mistakes. So our formulation, our compass, tells us that we want to help Maya build some self-compassion and forgiveness. And that's what's going to inform which communication tool we pick. Maybe we'll say something to her like, Maya, I wonder if it's fair to call yourself a total failure over just one mishap.
But Danny, let's pretend this is a totally different patient in the room making the same comment. Let's call her Allie. Allie's past experiences have led her to feel that she has no agency in the world. So Allie tends to externalize responsibility for everything that happens in her life, good or bad. So although Allie is saying the exact same thing that Maya did, my formulation, my compass is telling me something entirely different. I'm actually feeling proud that Allie took responsibility for the late pickup for her daughter. So how do I reinforce that agency a bit more? So for Allie, I might choose a totally different set of communication tools because the formulation's different. I might say something like, wow, Allie, sounds like you had a fumble today with that late pickup, yet I'm so proud of you for recognizing that you could have made a different choice. That's really hard to do.
Which would have been such an unideal and counter-therapeutic thing to say to Maya. So totally different communication tools in response to the exact same statement or behavior based on formulation. And in fact, if we sort of unveil the therapy a little bit or the curtain a little bit between different schools of therapy in the psychotherapy world, all of their bags of tools are relatively unique. They can look pretty different. An analyst might be doing an interpretation, an IPT therapist a role play, a CBT therapist doing a thought record. But what they all have in common is that they're all rooted in a very similar foundation of having a formulation as a compass to guide tool selection. And we're not going to go into the details of those formulations, but if you actually look at them closely, they're remarkably similar in content between the best therapists of any schools, just sort of packaged in different words and formats. So nobody here is looking to become a therapist in an hour, but how can we extrapolate some lessons, some tips from therapy training into our geriatrics and palliative care practice? We're going to go through a series of high-yield tips for how to concretely apply this concept of formulation to our practice. And intermixed in there, we're going to be practicing formulating some cases together today. The thing that I'll say before we get going, the thing I want to acknowledge up front is sort of this fundamental truth that basic humanity does get us far, right? They've done a lot of studies looking at what predicts successful outcomes in psychotherapy. And time and again, regardless of modality, one of the biggest reliable predictors is simply therapeutic alliance. So just being a person in the room, caring, present, engaged, one of the cornerstones of what we know to deeply value in geriatrics and palliative care is 9/10 of the battle. We know to sit down, to make eye contact, right? To acknowledge emotion. And today we're sort of going to consider all of those things, the great foundation from which to hone our craft. And in terms of building our craft on top of that foundation, the biggest action-oriented ask that we hope you'll hold on to with regards to formulation is to make explicit what you do implicitly as a means of practice. And I'm going to say it again, because if you forget everything else that comes out of my mouth today, I want you to remember this. Make explicit what you do implicitly as a means of practice. We're all thoughtful people, right? We know that it's helpful to debrief a family meeting. But Keri, do you remember when you were a trainee, what were the typical questions you got when debriefing a meeting?
In debriefing, it would usually be what worked and what didn't work.
Yeah, what worked, what didn't work, what would you do differently? And I would argue that the missing question is why, right? Why in this meeting? Why with this family? Because it doesn't matter just knowing what worked without the why piece, because without the why piece, there's no way to know if it'll work with other families in other meetings and which ones. So you all have a great intuitive knowledge of what a patient or family may need. You might say on rounds, gosh, I think we need to be a little bit more paternalistic here. Your intuition may be spot on, but even if it's obvious, go through the process of verbalizing the why behind these choices, like we do with why we picked a certain pain medicine over another one. It's how doing it explicitly is how we build the muscle. So I think we need to be a little bit more paternalistic here, because my sense is that the biggest holdup in their grieving process is the amount of responsibility the daughter is holding with each decision. Might be wrong, might be right, but challenge ourselves to go through it explicitly. And I not only encourage us to do this with ourselves, but as educators, I challenge us to sort of teach it explicitly the way you would any other skill. So, Keri, if a trainee came into you and you asked them what they wanted to give a patient for nausea and they answered, what would be your follow-up?
I would say, why that medication? Why did you use it?
Yeah. Can we all collectively add teaching questions to our repertoire that explicitly help trainees formulate and get at the why behind what's going on for our patient and family and how it informs our choices? These are questions like, what do you think the core struggle is for this family? How is that going to impact our approach in the room today? Right? So let's try this really explicit thinking through a sample case together.
So we'll practice the skill with a couple of geriatrics and palliative care case vignettes. But I want to point out that in our typical, more fully experiential formats, we usually try to talk this out and lean very heavily on the audience to formulate in real time. Because of our time limitations in the format of this talk, we're going to model some of what goes on in the workshops. And of course, we invite you to chime in the chat, although perhaps that's not feasible. But as you hear this, imagine that this is very much an interactive sort of process in many of our modules. So we'll start with a case that's probably familiar to many palliative care clinicians of always wanting more time. Decision needs to be made about the course of a patient's care. There's a big family involved. They listen to what the clinicians have to say, but they get stuck and seem unable to make a decision and often defer by asking for more time. Keri, Danny, I'm curious, when you hear this sort of very broad vignette, what comes up for you in terms of a set of potential formulations?
Yeah, there's so much that could be behind this. Keri, I think I see this sometimes in practice when there's some kind of upcoming milestone for a family and they're kind of trying to stall or hold out for that, and I'm unaware of it.
Yeah, and sometimes I see it when there's been a lot of mistrust in medicine. Maybe there's been a medical error that happened that caused that mistrust, or there's a fear of them being abandoned by clinicians.
Definitely. I think one of the most common things we see in palliative medicine is just the weight of these decisions. Family members are worried that they're going to get it wrong with this person that they love more than anybody in the world, and that can be crippling.
All right, I'm going to keep the brainstorming going on formulations. Another one that I saw last week is the patient herself was actually kind of the matriarch of the family, who was the one that made all the decisions, and she had lost capacity and was delirious. So that person wasn't available anymore. And so the family was disoriented on how to go about the decision.
Totally. And one of those challenging ones that we see in palliative care is the family that's waiting on a miracle, right? We're presenting all of this medical stuff to them, and they're holding out on something that's completely outside of the medical realm. So we can keep going, but maybe in the interest of time, we should.
Why don't we tackle a couple of these? These are great. And of course, we're keeping this purposefully broad to keep the differential kind of as big as it can be. But let's say that we're gonna go down the path of hypothesizing that our family is worried about making the wrong decision, that they feel overwhelmed by the weight, burden, responsibility of the choice. They're worried they're going to get it wrong. I wonder, Danny, can you share a little bit about how you would design your tools if that were your formulation?
Yeah, I mean, there's no one right thing, but this is a case where I would get a lot more directive and paternalistic than is normal for me, right? I might say something like, it's our job to take care of your father and support you. Would it be okay if I made a recommendation? I might even say something like, if I had a family member like your father, this is what I would be inclined to do. Which is not something I always say, nor is it something that I always should say. But here, we know our compass is telling us that we want the weight of the responsibility to go down with us rather than be felt solely by the family.
So that's actually fantastic. Let's pivot to a really different formulation and talk through how the tools might look very different, even in a similar case. So let's go with mistrust of medicine. And let's imagine that this family, the hypothesis about what's going on is that the family feels distrustful of the clinical team. They worry the clinicians are giving up on their family member, or that they're somehow pushing an agenda that's not particularly beneficent onto the family or the patient. Keri, how would that maybe inform a different set of communication tools that you might use?
Well, with that formulation, I would think a lot about wanting to give the family as much agency as possible. So I would try to lay out all the options and ask a lot more patient-centered questions to really get to know their understanding and really give them as much control as possible, asking questions like, what do you think so and so would want under these circumstances if they were here?
Yeah, and that question, Carrie, what do you think your father would want? Would work great in your formulation, but you can really imagine how that would be could be a very detrimental question for a family who is so worried that they're going to do the wrong thing by their loved one. So
Yeah.
we have a bit of a love-hate
Yeah,
relationship with
this
that
reminds
question.
me, Danny, that it is okay to say the wrong thing. So formulations are fluid and we can simply adjust them as we get more evidence. And we have 5 tips to share with you today, 5 take-home tips. And this first one is the fact that formulations are fluid. And that comes from the fact that formulations are not as clear-cut as a diagnosis. Rather, formulation is actually an educated guess that helps guide us. Once we have consciously contemplated the formulation, if we hit resistance or get stuck, that just gives us more data to adjust, as opposed to alternative situations when something isn't working. One of my trainees said, Keri, I just feel like sometimes I'm throwing spaghetti at the wall of communication skills, hoping a communication skill just sticks with the patient. And then the trainee said, with formulation, I actually have a strategy that's a lot more personalized. So if the communication tools aren't working or therapeutic, and then it's an indication that maybe our formulation is off. Maybe the patient and family just weren't ready for that particular intervention yet. Or perhaps the communication tool was a mismatch with the formulation itself.
Totally. We've all had these moments when we're saying something and the train just goes off the tracks, right? Or we're throwing in catalyst after catalyst and the case just won't move. And these are the moments when we can say to ourselves, gosh, I thought this was going on. And then I said XYZ and they shut down. And I realized actually this is going on, shifting our compass in real time, like Carrie was talking about. Or I realized I'm not sure what their core issue is, in which case our goals have to shift to understanding them better.
Piggybacking off that goal, I think it's important to recognize that there are countless sources of data that inform our formulation. And we are constantly, in every clinical interaction, in every data point that we receive, we are integrating it into this evolving dynamic formulation. In psychotherapy, when we're formulating around a patient, we might be thinking about their life history, their longstanding relationship patterns, their symptoms, but also the relationship in the room that we experience with the patient, how the patient is feeling towards us or their transference towards us, what our reactions to them or our countertransference. Those are all things that may also inform our formulation in geriatrics and palliative care and in serious illness communication more broadly. Even if the scope and the nature of the data may be different, we may not have very detailed childhood social history, but we're still getting bits and pieces of information. Furthermore, we also have other sources of data in our work that sometimes psychotherapists actually don't have access to. We have the experiences and observations of the referring colleagues that we work with across disciplines, and of course, the richness of our entire interdisciplinary team's clinical impression. So in my own work, I rely heavily as I formulate on my social work colleagues, on my chaplaincy colleagues, on our learners at different levels. And that's a real privilege in terms of moving care forward.
All right, team, let's dive in together to case 2. This is a case about too many questions, which I think is pretty relatable. We've all seen a patient like this. So this is a case where every time the patient comes to our geriatric clinic, he has numerous detailed questions about care choices and medication choices. He asks questions for much longer than you or the team have available. So let's try to think together, Danny and Dan, if you could just brainstorm what might be some of the formulations behind this case.
Dan, I definitely see this, I think, in cases where it's hard for a patient or family to face the bigger picture. And so they kind of stay in the weeds as a way to avoid the greater devastation of what's going on with them.
Definitely. And I mean, just going back to the first case, not to be too repetitive, but mistrust of medicine. I mean, I think people that have had bad experiences with clinicians often want those extra details. They want to test us. They want to get the safety and security of making sure that they're getting the information they deserve.
I'll throw out, maybe this is how they are all the time at baseline. If any of you in the audience know me personally, you know that my husband laughs when he goes out to dinner with me, because to pick an item off of the menu at a restaurant, I tend to ask the waiter so many questions, like, is there cream in it? And which one do you like more? And it's just my decision-making process.
And as we're talking about it, I realize often in these situations, I think about control, which is such a pivotal issue for people who are navigating serious illness, and how much it can help people reaffirm their sense of control when they have something concrete to hold on to.
Yeah, Dan, let's start with that one then. So that's a great exploration of various formulations. And let's just go with this one that you mentioned, Dan, the sense of loss of control. So let's say this is a patient where for him, focusing on investigating and understanding the details of his illness actually makes him feel a lot more stable and grounded and intact. So Dan, what might be some of the communication tools you would consider if that was our formulation?
I'm going to extrapolate a bit, Keri, and just assume that actually this is happening in a way that's useful to the patient, that isn't preventing their care from moving forward. And if that's the case, I really sit down with them. I would carve out time every day to explain the details. I would advocate to other clinicians to really try to create that time. I would have the patient take agency by writing down their questions and ensuring they get to make sure that they are addressed in meetings, to set predetermined meeting times and agendas during family meetings to make sure that the patient has agency in setting that agenda. But also to attend to the existential and the sort of underlying psychological experience of loss of control while doing that, and really reflect the difficulties of having one's world turned really upside down by a serious illness.
And I think in our brainstorming earlier, we also mentioned avoidance, where maybe the patient is asking a lot of questions simply because he's trying to avoid everything possible to avoid the truth of his illness. So asking these detailed questions actually helps deflect the bigger picture and the reality. And this reminds me, especially what you just mentioned, Dan. This case highlights this discernment of whether the defenses both serve or don't serve the patient. So um, both of these are defense mechanisms when we think about, the sense of asking too many questions because of loss of control versus avoidance. However, in the first one, as you mentioned, Dan, we notice that it's actually serving the patient more. It's making him adapt and feel intact and helping him work through things. Versus in the second formulation, in the terms of avoidance, it does not seem to be serving the patient. It's actually it's becoming more of an obstacle. So that's a really helpful distinction.
Yeah. And I love this point you're making, Keri, about how we can formulate the defense itself, because it takes us out of this dichotomy of thinking of people's defenses as good or bad, right? Their defense is there for a reason. And the ways that it serves or hinders can change in different time, can change in different settings. And so formulating the role of that defense for a specific person in a specific setting is what helps us tailor what we do with it, right? Are we going to lean into it? Are we going to lean away from it? What's going to serve the patient in front of me?
Yeah, I always ask myself, Danny, like, does this actually help or hinder the patient whenever I see a defense at play? Because they're always before us, these defenses. And I had a case last month where a patient had a lot of intellectualization. And on one hand, at the beginning, it was really serving him well. He was able to stay up on his latest imaging and creatinine and GFR. But then all of a sudden we were trying to do a family meeting and talking about the intense, the prognosis before him. And all he could focus on was the creatinine and the GFR, and he couldn't integrate it emotionally into the big picture because he was just still intellectualizing. And, similarly, I think about compartmentalization as another defense where on one hand it can serve, where we had a patient a few months ago that he was able to compartmentalize his poor prognosis, put it in the box, and go off to Disneyland with his two kids and just enjoy the moment of being there on that vacation with his family and set his prognosis aside in his mind. But then it could be an obstacle, if you keep it in the box for too long and can't get it out in the family meeting and think about the poor prognosis, it could become a barrier to medical decisions. So we digressed a little bit, but we're coming back now to this case two about avoidance, where Danny, if you saw a case like that where it was an obstacle, what would be a communication tool?
Yeah, this is a situation if they're in the hospital where I will extrapolate and say I probably am going to want to try to lean away from it, but in a way that they can tolerate. So I might end up picking a communication tool that's a lot more bodily, right? With a patient like this, that's got this kind of anxious energy, I sometimes feel anxious and want to get out of the room. But this is when I would really sit down into the chair. I would relax my body. I would take a deep breath. I would make a comment about sitting with this. And they very well may, and then I probably ask, our big picture questions. I pull those out of the toolkit. What are your greatest hopes? What are your biggest fears when you look forward? They may divert right back into the detail, but our compass stays our guide as long as we think it's accurate. So I'd again take another slow, deep breath and say something like, gosh, there are so many moving pieces. It's hard for even me to sit still with all that's going on. Right. And for some of us, this approach might come very naturally, but I personally run kind of anxious. So I have to be very mindful about my emotional tone that I'm emitting in an encounter like this. That very well might not be true for you, Keri, or for you, Dan. It might come a lot easier to you, which is totally fine, but it gets at our next tip, which is to know yourself. Right? My natural style, my way of being and communicating is a really good match for what some patients need. But there are certain other patients that may need something different. And for those patients, I have to come off of autopilot a bit more. Maybe I have to strengthen up my boundaries. Maybe I have to be a bit more formal, use a little less humor than is natural to me. Any number of things that aren't completely natural to me, but I think will be experienced as more therapeutic for a specific patient based on my formulation. And if we do think that adjusting or bringing a different part of ourselves will be experienced as more therapeutic, we really strive to find an authentic version of how we can deliver something to address the need, which is why it's so nice to have a wide and varied toolkit of communication tools.
It also reminds me of our fourth tip here, Danny, that formulations can happen on multiple scales. So as clinicians, we are in no way expecting ourselves to deeply formulate a patient's full psyche the way that a psychoanalyst might if they were following a patient for many years. Like I've had this case supervisor with a psychoanalyst, and she's always said to me when I present palliative care cases to her, she's like, Keri, you can even formulate a 5-minute moment with a patient in a pain crisis in the emergency room. Even just that quick snapshot, you can get some rich data in there to create a formulation. So we can formulate anything from a moment in the emergency room to an interaction with a patient or their family member in the hallway to a core struggle in a patient's coping pattern, maybe to a family dynamic we might observe during a visit, to a team dynamic, or potentially to a person's fuller psyche, especially if we've known them and followed them in the outpatient side for a longer period of time.
So marching forward to our very last case of the day, you get called in to join the family meeting of a patient and family that are unfamiliar to you. Your intern begins by asking, can you tell me your understanding of what's happening in your father's care? The patient's adult son replies, you're the doctor. Don't you already understand what's happening in my father's care? The intern attempts to clarify. Sometimes it helps us to understand the family's understanding of the situation. Becoming more frustrated, the patient's son replies, we understand. If there's something you're worried that we don't ask directly, what is the point of this meeting? And this meeting did actually happen to me in real life, and it escalated from there. So Dan and Keri, I'm going to ask you, what might have been going on underneath this behavior? What are some potential formulations?
For me, frankly, we all come into a clinical encounter with sort of the cultural context that informs what we expect from our clinicians and the relationship. And I wonder whether it be the family culture or broader cultural sort of misalignment was going on here between the team or the clinician and the family.
I think too, Dan, about family meeting fatigue, especially on the inpatient side, where
Yeah.
maybe this is their fifth family meeting in the past 2 weeks, and they're just exhausted by the healthcare system in general and being asked this all the time.
Another thing that we see all the time, and we don't really talk that much about in palliative care and geriatrics, is the idea of displacement that this family and this patient are dealing with really likely a really horrible situation. And it may be that some of what's happening here is not necessarily about the intern or the clinical team, but really a reaction that is just being kind of projected onto this intern that's more reflective of just how terrible this is.
Sometimes I also, Dan, have to kind of broaden out my formulations to think about spiritual misalignment or religious misalignment. This might be a family or an adult son that really copes through religious coping, and we're not connecting with that well.
Yeah, that's a great point. Well, continuing on what I was thinking about with displacement, something I often say when I'm wearing my psychotherapy, my psychiatry hat, it's a lot easier to be angry than it is to be sad. And I'm wondering also whether there's some degree of anger as an expression of some grief here.
So
How do we do, Danny, on our brainstorming?
this could go for a while, so I'm going to stop you in the interest of time and have you run with a couple of these. So let's go with cultural misalignment. Danny brought this up. Maybe the way that we are communicating is culturally non-concordant with their expectations of what care should look like. And it's making it hard for this family to feel trust, to feel comfort, to feel containment. Dan, what tools might you use in this case?
Yeah, I'm a huge fan of process comments in situations like this. And what I mean by that is actually just kind of saying what's going on. I'm here to be helpful. I'm obviously not being helpful to you. Let's sort of pause, take a time out, and just sort of like figure out how I can actually adjust myself to be useful to you and understand what's going on. And I think people often don't expect that. And it's a really nice way to diffuse some of the affect and say, like, hey, and you seems like you want to bop me on the head. Like, what's going on here? What should I be doing to be more useful?
Yeah, in the real life version of this case, this ended up being the formulation, and naming the fact that we had upset them was really important, but also they were able to tell us they needed us to be really direct, and all of the care providers becoming a bit more of like a beneficent, paternalism ended up being so containing for this family at the end of the day. Keri, let's go with another one. Let's say that it is a spiritual or religious misalignment. This family feels that God is the ultimate authority who governs the outcome of decision making. And they feel misaligned with this assumption that the doctors are the ultimate experts. And this is what's making them bristle as we come into the room, to drop whatever information we have to drop.
Yeah, and this is a moment where I think leaning into that spiritual paradigm is so critically important. Actually, trying to validate and grasp a deeper understanding of that spiritual worldview that they hold within them. And definitely utilizing spiritual care expertise, our chaplain expertise to assess the coping and to get a better understanding of how they view suffering in that spiritual worldview, as well as trying to become sort of primary spiritual care experts ourselves and like building up that skill set.
Totally. I feel like sometimes when it feels like our paradigm and the family's paradigm is at odds, our instinct is to better explain to them where we're coming from. But what ends up moving the case forward ends up being really going deep into their paradigm and then sharing what our input from within their paradigm, right? What does a miracle look like to you? What does God need to be able to do his will? Any number of questions that helps us come into their paradigm and then be in a place where they're receptive to the input we have.
I really appreciate these formulations because I think one of the concerns that we often hear as we're teaching this from our participants is whether formulating, which we inherently do through the lens of our own experiences, can discount or devalue the role of individual patients and families' cultural, spiritual contexts. And when I hear this, I'm always happy to hear it, and we should be thinking about this. But we always try to emphasize that the formulation is really happening from a stance of curiosity and humility. Rather than the sometimes more typical clinical stance in which the clinician has knowledge that they're imparting or using to help the patient. Actually, in psychiatry, there are even tools to help guide psychiatrists and psychiatrists and other clinicians in exploring sort of how cultural and religious components contribute to patients' experiences, and in exploring if they're actually discussing and having the patient be the expert, thinking about them collaboratively about what the formulation is and how the patient's context might fit into that formulation.
This leads us to our fifth and final tip of the day, and that's that formulation actually leads us to greater empathic attunement. So our Pally Psych team sometimes gets questions like, well, isn't this whole process of doing formulation just leading us to label patients or judge them or be presumptuous about knowing more than what we actually know? And the answer to that is absolutely not. The spirit of doing a formulation is actually one that allows us to be more expansive, more personalized in who that patient is as a person. So it comes from a very non-judgmental presence of open curiosity with a positive regard for the patient to understand their inner core struggles much more deeply. So then we can feel more emboldened and equipped to actually have more empathy and attunement and therapeutic presence.
Keri, perhaps an extreme example, but I'll share. I have a patient in my outpatient practice, and she has borderline personality disorder. And every time I have to space out the sessions because she doesn't have any palliative care needs, she gets so mean. She gets really mean to me. She'll say things like, "You are causing me harm. Did you come into medicine to inflict suffering on others?" And without formulation, I feel like my psyche would probably crumble in the setting of being told stuff like that. That's very hard for me to hear, but it's formulation that helps me stay empathic with her. It's me holding on to the fact that she is so triggered by a sense of abandonment, by a fear that people don't care, a fear that people are throwing her away. And that deep trigger is what's coming out at me in this anger. And holding on to that not only helps me keep empathy, but it also helps me feel rooted in my approach to dealing with it. So we're close to the end here, so I'll give you some takeaways. Number one, I hope you guys are all leaving with the sense that, psychotherapeutic concepts can be directly relevant and directly applicable to serious illness care. And that shifting the educational paradigm to build them into the schema of how we routinely approach cases, right, to sort of bridge this gap can elevate our knowledge and skills in our practice. And then honing in on one small example that we went with today, a formulation, that formulation can optimize palliative care communication, and that it helps us to mindfully respond to people rather than simply react to a situation. And that the most concrete first step we can take is the simple act of pausing and asking ourselves why, right? Of making explicit what we do implicitly in our practice. And bearing in mind the tips that formulations are fluid, we adjust them with more evidence, that multiple data points can inform our formulation, that self-reflection is an important ingredient in making use of formulations, that they can happen on multiple scales. So you don't be intimidated, just take a stab at it. And that formulations ultimately are meant to lead to greater empathic attunement. So we did put some references in the slide. They are helpful. And I'll just say thank you. Thank you for having us here, for spending this time with us. It's so lovely to talk about something that the three of us love so much. Truly, we're nerds in this space. We delight in discussing this stuff. So please feel free to reach out at any time with questions, feedback, reflections. And with that, we have a little time to open up to questions.
Terrific.
Yeah.
Thank you so much. Really appreciate what a great talk about how communication tools really are not a one size fits all, and to be very thoughtful and explicit about that. That's terrific. And just as a preface, as we're thinking about questions on over here, is we actually have mailed 3 plaques to each of you. Thank you for being one of our grad round speakers. And the plaque will say teacher affects eternity. So thank you very much for teaching us this very important skills. So maybe I'll ask the first question, then open it up for the room. I'm curious about formulations, and I'm also thinking about in geriatrics, and I also think a lot about ageism, and how do we make sure we're checking our biases when we're making these formulations and not assuming, oh, this person has dementia, but actually they just don't have the hearing aids. Or I'm just thinking about all the things that sometimes go into misformulations, and how do you sort of guard against that?
Yeah.
I'm really glad that you're bringing up this piece about unconscious biases, because in our workshop, that's why we spend so much time on this topic of countertransference. So thinking about our own emotions, reactions, experiences when we're in the presence of a patient, because what we can't say with words or acknowledge within ourselves will come out in these aberrant behaviors of just sort of, like you said, presuming something and moving forward with a plan without thoughtfulness. So I think having that self-reflective awareness allows us to bring those unconscious biases to the light and ideally to have more inclusivity.
Yeah, we always teach people actually the order we do it for their practice is what did this bring up in me, right? The countertransference, and then what do I think is under it for the patient, and then how do I want to mindfully respond? But the other piece I'll bring up that came up in the talk is that the big frame shift I think from medical culture for formulation is that I am never 100% confident in a formulation. I could know you for 15 years and might not be 100% confident in a formulation because it is always like infused with humility. It's always considered a hypothesis. And for that, I think that mindset with formulation helps you not get stuck in something that is wrong. But I appreciate the comment.
Other folks in the room or online? Alex.
Is there a step in which you like check in and try and suss out your formulation, or do you recommend just sort of jumping in and trying out one of the tools that's appropriate to the formulation you have in your mind?
It depends, Alex, on the formulation. It depends on the formulation. There are some patients for whom it is so therapeutic to have you give words to their formulation, to have it be spoken and heard, and you say it to them, and you say it with different degrees of confidence. Sometimes you wonder, like, I wonder what it must be like to imagine a world without him, right? You wonder about it, or you say, you know, like gently, like talk about how some patients really struggle with XYZ, and you see if it hits. And there are other patients who you think need to hear it, but they can't hear it in its full version. So you digest it, you water it down a bit, you put it in a package they can hear, and you say it because you think it will serve them or because it's going to help you figure this out. And then there are other patients. When my borderline patient yelled at me, "Did you come into medicine to harm people?" I didn't look at her and say, "I know what's going on here. You're really triggered by a sense that I'm abandoning you and that you're worthless to me. And that's why you're mad," right? And so it just wasn't appropriate in that case. So it truly depends on the formulation, whether or not it's going to be therapeutic to share and test out the formulation.
Beyond just the formulation, I would say it also depends on the context. I mean, when I wear my psychiatry hat, if I'm covering CL and someone is extremely agitated and trying to punch one of the staff members, I'm probably more doing the let me just go with the formulation. If they're agitated and they need a medication. If I'm in a psychotherapy room with a dynamic patient, they're very upset. My approach to that, my willingness to share that with them and to sort of like be a little bit more open-ended about it differs. And I think similar corollary, certainly in palliative care, of sort of what the urgency of the situation is and whether you can afford to not act or whether you have to make an intervention. But I think anytime you make an intervention, whether you're aware of it or not, you've got a formulation. So it's not even like a practice changing thing as much as being aware of the fact that something is driving the decisions you've made therapeutically.
And I do notice there's a question in the chat that might be of interest to other folks about how can they attend the SWHPN half-day workshop in August.
That's a good question.
I answered it, Danny. I put a link into Swiffin's event page. Both members and non-members can register for that. It's all the way at the bottom of that event page. It's called the Summer Summit.
That's a better answer than I would have given, Dan. Thank you for that.
Alex.
I have another question. A lot of times in geriatrics and palliative care, we work in meetings with groups of team members, and different team members may have different formulations for what's going on with a patient or family member, and may be tossing out tools that are appropriate to different formulations. And I wonder how that plays out in practice, because it's almost like, if you don't agree at the outset on a prognosis, then it's really hard when that disagreement plays out in the family meeting. I could imagine the same thing is true when different members of the team have different formulations about what's happening.
Yeah, I'm really glad that you're highlighting this observation, Alex, because I'll often try to embed my working formulation even into a pre-meet, let's say before a family meeting. In a pre-meet, we often will talk about what do we think the prognosis is? What are the actual therapeutic options in terms of like medications or more cancer-directed treatments? And then I'll also include oh, and I think that potentially some of their biggest hiccups or inner struggles might be this. So I wonder if we had a more paternalistic approach or gave a recommendation during this meeting, it might help relieve them of the guilt. So I'll embed that into the pre-meet just to see if I can get alignment. Because to your point, if you don't have alignment, then it could be it could potentially be harmful or just disorganizing for people.
Like so
Also
helpful.
think that actually I'm sorry, do you want to go Danielle?
Oh, I was just gonna say, I think it's so helpful sometimes for our colleagues as from other specialties too, like to be so explicit in our thinking with them in a pre-meet like that, because it's really nice for people to all go in with a compass. But Alex, if there's true debate, like if you've discussed it openly, like what's the formulation and people don't agree, well then gosh, shift the goals of that meeting. Like shift the goals of that meeting to figuring out your formulation and all going in there and like floating some of these things and figuring out what this family's core issue is, because that's actually going to get you to the finish line faster, even though it feels like you're slowing down. And the other thing I was going to mention is that we're often formulating other teams, not in a mean way, like again, from a place of empathy, like what is so hard about this case for this team? Like what is going on with them? What is it that they need from us? Do they need us to give them permission in this family meeting to say there's nothing else we can do? Do they need us to, agree with their prognostication skills? Like what do they need from us? But Dan, you also
Recognizing
Yeah,
that yeah, behavioral states can sometimes be infectious. And so, similar to countertransference, we might pick up with a patient, that team might actually be doing a parallel process where their behavioral patterns are actually mimicking what's going on with the patient or family as well.
told
So
you we were
all of this
nerds.
is data.
Told you.
well, the other thing I would say though is that there are often situations where people on the team have very, very different formulations about the patient that actually reflect something that's going on with the patient or with the dynamic. So for me, actually, part of my evolving the formulation is very much driven by an experience like meeting a patient on my own and hearing an extremely different perspective from my social worker chaplain colleague, because that in and of itself might be giving you some hints about what's going on, that are more than just sort of incongruity in the team and that are probably important to factor in as you think through a case. At least that's my take on it.
Good point. It's a good data point. Are they projected or presenting themselves differently with different people?
I know we've hit the top of the hour. Any other questions? Looks like we answered everything. So thank you. Thank you so very much. That was really terrific.
Thank you for having us and hosting us. It was really exciting.
Thank you.
All right. Take care, everybody. Have a good night.
Take care.